Good afternoon and many thanks for joining us, and welcome on behalf of BIOHIT to our sponsored Silence Symposium. We're very pleased to introduce Dr. Andreas Hadjinicolaou from Addenbrooke's Cambridge University Hospital. And he's talking today about optimizing endoscopic yield in gastric cancer, a risk-stratified approach using serological biomarkers. Thank you, Andreas.
Thank you, Angela. Thanks for the introduction. Can I just confirm that you can hear me? Yeah, thank you. Okay, so thanks for joining today in this Silence Symposium. As Angela said, I'm one of the gastroenterology consultants at Cambridge University Hospitals and an affiliate academic at the University of Cambridge. I have an interest in optimizing early detection of upper GI cancers by improving endoscopy quality and by using non-invasive biomarkers. And today I'm going to try and take you through a little journey with regards to stomach pathology, how we recognize it and how we can improve it, and how we can use risk stratification based on serological biomarkers. So these are my conflicts of interest. It's not really a conflict of interest, but as part of the CyGIM study that I am co-leading with Masi Di Pietro at Cambridge, we are evaluating the gastro panel. Right, so why are we interested in gastric cancer? It's the 6th commonest cancer and the 3rd leading cause of cancer-related mortality in the world. In the UK specifically, it's the 16th most common cancer with about 6,500 cases every year and responsible for over 4,000 deaths every year. Approximately 55% of these cases are thought to be preventable with earlier detection and prompt intervention. The overall 5-year survival is very poor at about 20%, which is similar across the world and in the UK, and this is mainly due to late diagnosis at advanced stages. When you pick this disease early at stage 1, for example, your 5-year mortality improves and survival is about 75 to 80%. And we care because biologically it makes sense as well. We know that gastric cancer develops through a sequence of recognizable precancerous conditions such as gastric atrophy and intestinal metaplasia. And here I'm showing you the Korea cascade. Korea was the first one that described this sequence and demonstrates this stepwise progression from normal mucosa through to H. pylori related or autoimmune related chronic gastritis, then to atrophy, gastric intestinal metaplasia. Those are the 2 in the red box that we really want to be able to pick up and then surveil these patients. If you don't and you allow this to progress, it will go to dysplasia and then gastric cancer. Progression to gastric cancer is comparable to other premalignant conditions such as Barrett's esophagus with an annual incidence of 0.1% for atrophic gastritis, increasing to 0.25 for intestinal metaplasia and up to 6% for significant dysplasia. So can we do better? The answer is yes, because we know that in countries with high incidence, such as Japan, South Korea, parts of China, there is a national endoscopy screening program for gastric cancer, and this has led to reduction of gastric cancer by 47% and an increase in the overall survival of these cancers up to 76%, so essentially the early stage of gastric cancer. However, in areas such as the UK and other parts of Europe where the incidence is low to moderate, population-wide endoscopy doesn't make sense. It's not cost effective, and it's the only current validated screening test we have. Why are we interested in gastric atrophy besides gastric cancer? Well, it can lead to pernicious anemia, secondary to vitamin B12 deficiency. This is because of the loss of stomach parietal cells, which produce intrinsic factor. Without intrinsic factor, you cannot absorb B12. Iron deficiency anemia, again, because of reduced gastric acid, there is reduction in the absorption of iron. There's other trace element deficiency, such as zinc, magnesium, and calcium, again related to the gastric atrophy. And of course, you can get gastric nets, which can eventually metastasize. And this is again because of the overproduction of gastrin secondary to the loss of acid from the stomach, which stimulates hyperplasia of the enterochromaffin-like cells in the stomach, and this can develop into a net, as you can see in the picture. So how are we currently diagnosing gastric atrophy and gastric IM? So on the top left, you can see a nice juicy stomach with multiple folds. This is how normal stomach you should look like. And on the right-hand side, you can see an atrophic stomach. You can see the pallor with a thin mucosa, loss of the gastric folds, prominence of the vessels, and the atrophic border. And then lower down, especially when you use narrow band imaging, you can see gastric intestinal metaplasia very clearly. You can see these patchy areas, often with the light blue crest sign that is pathognomonic of gastric IM, and the alteration of the pit pattern from the round pit that you get in the stomach corpus to the intestinal elongated pit pattern that you get with gastric IM. So what is the problem then? Since we know about the biology and we know how to identify these lesions, we should be doing okay. But that's not the case. And let me demonstrate this through two cases, and I'll try and explain what the problem is. We've got a 26-year-old patient coming for endoscopy, abdominal pain and bloating, background of IBS, fibromyalgia. This is your typical nightmare patient, essentially. Okay, the endoscopy is very difficult to do anxiety, sedation doesn't work, there's a lot of retching, the patient needs reassurance, and of course the endoscopy is normal, clot test is negative, no Hadjinicolaou pylori. You probably knew that to begin with based on the indication, if I was to ask you. And then this is our second patient on the same list. At the end of the day, you're already very tired, you're late, and you're rushing. It's a 66-year-old with abdominal pain, nausea, early satiety, so clearly more red flags. Upper GI endoscopy on the same list, last slot, and this is identified as gastritis. No biopsies taken, no enhanced endoscopy imaging utilized. And I've got Amar here looking at this, and he knows where this is heading to. So this comes back 2 years later, ongoing worsening symptoms, anorexia, weight loss. This is now an advanced gastric cancer that was missed, and this is a PUGIC. So this is a post-endoscopy, post-upper GI endoscopy cancer. And these are potentially avoidable in about 70% of cases based on the root cause analysis. So this demonstrates these two competing problems. So problem number one, we've got a huge number of routine, low-yield upper GI endoscopies, utilizing the resources, increasing pressure on the endoscopies, such as yourselves, and stretching the waiting list for the patients that really need the endoscopy. And then the second problem is that even when we do the endoscopy, there's poor recognition of the premalignant stomach, and therefore a missed opportunity to recognize these patients that are at high risk of gastric cancer. And we recently demonstrated in a multi-center UK study called Prospero that only 15% of patients undergoing an upper GI endoscopy through a referral pathway actually had significant pathological findings. And this suggests that up to 85% of these patients probably could be spared an invasive investigation or postponed. However, we've got increasing referral rates for endoscopy, as you know, and this particularly affects patients of lower socioeconomic status that have poor access to endoscopy. I also truly believe that the high pressure we see in endoscopy leads to the poor recognition and the poor quality of endoscopy. And these findings actually mirror the National Endoscopy Database findings that showed that about 3/4 of gastroscopies are done on patients with less than 1% cancer risk on the pre-test probability, and about 90% of studies were actually normal or had very minor findings. So what we really want to focus on is having our efforts and ability to identify the early premalignant lesions that we can surveil or treat, and avoid going straight to advanced gastric cancer, similar to what we do in colonoscopy with FIT tests, similar to what we do with Barrett's, and very recently we're re-stratifying patients in Barrett's based on capsule sponge, for example, to modify the conventional pathways. There's an unmet need to develop non-invasive tools for gastric cancer early detection, and this is highlighted in the latest BSG guidelines, which admittedly are a bit old, from 2019. And here you can also see that what we're looking for is these high-risk atrophic gastritis that needs to be surveilled every 3 years. So this brings me to the currently available biomarkers and the potential solution to these problems. So there are currently 2 commercially available serological tests for gastric cancer cleaning. GastroClear is mainly based in Asia. It's based on 12 microRNAs measured in the blood, and it has a sensitivity of 70% and specificity 75% for gastric cancer. It's not useful for premalignant lesions. The GastroPanel, on the other hand, is a point-of-care rapid test. It also exists as an ELISA test, and it's based on 4 protein markers, and it's primarily designed to test for Helicobacter pylori infection and for chronic atrophic gastritis. All you need is the lancet to draw a drop of blood, put this in the cassette that I'm showing you here, and then the small GastroPanel reader machine. So how does it work? As I said, it identifies and measures 4 different targets. Antibodies against Helicobacter pylori. If you've got a positive test with more than 25 units, then you know you've got a previous or a current Helicobacter pylori infection. Gastrin 17, which is secreted by the G cells in the antrum, stimulates acid production by the parietal cells in the corpus, and this creates a negative feedback loop that stops gastrin production via somatostatin. If you get a positive test of more than 7 picomole per liter, this probably suggests atrophy in the body or use of PPI, which can create a false positive test. So you have to stop PPI for about 2 weeks before you run the test. If the test is too low, this could represent antrum atrophy, specifically with loss of the G cells. Then we've got pepsinogen 1, which is released by the chief cells of the corpus and reflects the structure and the function of that area of the stomach. The test is positive if the measurement is less than 30 micrograms per liter and suggests atrophy in the body of the stomach. Pepsinogen 2 on its own is less useful because it's made in the entire gastric mucosa, but the test is positive and can suggest gastric inflammation. What is really strong is when you have a combination of low pepsinogen 1 and a low pepsinogen 1:2 ratio, which strongly suggests atrophy in the corpus. And this doesn't just show you what's happening with a test, it shows you the biology and the function of the stomach. So let's see what's the current evidence in the literature. This is an old paper now from a European consortium that summarized the studies up to that point on the application of stomach-specific biomarkers for the non-invasive diagnosis of atrophic gastritis. And this provides the rationale for the interpretation, as we will see shortly, but you've got 4 quadrants, antrum and corpus, based on the different results that you've got of gastrin 17, pepsinogen, and Helicobacter pylori. And it might be better visualized here in this summary box. So if you focus on the red boxes and the orange one, so what you can see in the orange one is everything is normal, but the gastrin 17 can be also high, and you've got a positive Helicobacter serology. This suggests non-atrophic Helicobacter-related chronic gastritis, which should be treated. If your pepsinogen 1 or pepsinogen ratio is low and the gastrin 17 is high, you probably have atrophic gastritis in the body of the stomach. If the pepsinogen 1 and the ratio are normal, but the gastrin 17 is low, then you've got probably atrophic gastritis in the antrum. And if you've got pepsinogen 1 low, pepsinogen 2 normal or low, and a low ratio with a low gastrin 17, you probably have pan-gastritis. For any gastric atrophy, there's been an Italian cohort that showed 82.9% sensitivity using the serum biomarkers, and a meta-analysis of 20 studies showed a sensitivity of 75% and a specificity of 95.6%, and this is for any atrophic gastritis. More recently, 2021, large Finnish study, clinical validation for patients referred for gastroscopy, specifically looked at moderate to severe gastric atrophy, which is the clinically relevant one with the highest risk of gastric cancer. And what they show is a ROC analysis showing an area under the curve of 0.998, which is extremely strong, and an overall agreement with the updated Sydney system of about 91%. And when you convert that to something more practical, a post-test probability for having the disease using Fagan's nomogram, you can see that there's an 80% probability of diagnosis on endoscopy if the test is positive, less than 1% probability if the test is negative. And essentially, to cut the long story short, this was reproduced in a UK single-center prospective diagnostic accuracy study from Homerton Hospital, where there were paired biopsies and blood samples. Overall agreement 90% with a kappa of 0.83, 0.96 area under the curve for the pepsinogen ratio, and again, very similar rule in, rule out numbers using the nomogram. And this just brings me to the final set of results I will show. This is the CyGIM study that we're currently running in Cambridge, along with Massi Di Pietro. This is an investigation on the cytosponge and other molecular biomarkers to identify patients with gastric intestinal metaplasia. It's a case-control study. Cases have a diagnosis of proximal gastric IM. Controls have upper GI symptoms, no known premalignant conditions of the upper GI tract. We take bloods for serum biomarkers using GastroPanel. We do the capsule sponge, and we take paired endoscopy and biopsy samples. And the objective is to determine the accuracy of the capsule sponge to detect gastric IM and evaluate the utility of other biomarkers to add on to that that test accuracy. This stems from a previous study where we looked at the post-hoc analysis of the BEST-3 trial, and we essentially showed that in patients that did not have Barrett's but were positive for a capsule sponge test, they in fact had premalignant stomach in about 1/3 to half of the cases. And none of the negative tests actually had a premalignant stomach, which suggests that we can sample the stomach using the capsule sponge. Now, this is the preliminary results from the CyGIM on pepsinogen testing using the Olga classification for gastric atrophy severity as a comparison. So the Olga is a histological staging system that stratifies patients based on the severity and the topography of gastric atrophy to estimate gastric cancer risk. The higher the score, the higher the risk to develop gastric cancer. And what you can see in this ROC curve is that the area under the curve for pepsinogen ratio is really strong, is 0.95 with a sensitivity of 90% and a specificity of 100%, which suggests that it's a great tool for ruling in or out clinically relevant gastric atrophy, because this is compared to Olga scores of 2 or more, which are the clinically relevant one for surveillance and risk of gastric cancer. And here I'm showing you the breakdown by the stage of Olga with pepsinogen ratio in dark blue, pepsinogen 1 on its own in light blue. You can see no positive test for pepsinogen ratio in stages 0 to 1 and 100% for stages 3 and 4. The correlation is very strong, 0.85 coefficient, statistically significant. The BSG suggests that we can identify individuals with extensive atrophic gastritis using these serum biomarkers, but obviously that's not recommended for general screening in the population at this point because it's not cost effective and there's low incidence. I'm going to skip through this slide, but essentially we don't have evidence whether this is cost effective in symptomatic populations. It's not cost effective in the wider population. Just to show you the costs, £35 for the GastroPanel, £470 for a gastroscopy. So to put this in context, this is a modified pathway of what the future could look like. So you've got a patient with dyspepsia symptoms, but no risk factors. So less than 50, not male, not smoker, no family history of gastric cancer, no obesity. They can have the GastroPanel instead of an endoscopy. You would do an endoscopy if there are red flags. And then depending on the result of the GastroPanel, you can proceed accordingly. If you've got a low risk result in green, then you can do primary care management and then surveil for symptom evaluation and symptoms getting better, and defer the endoscopy. If there's an intermediate result, such as Helicobacter pylori, then you treat and reassess. If you've got a high-risk result, for example, an atrophy pattern with low pepsinogen ratio, then you send this patient for a priority gastroscopy, and your endoscopist is alerted that this test was positive and has a high vigilance to look at the stomach for these pathologies. So to conclude, I hope I've shown you that serum biomarkers are promising, and the question is no longer can they detect atrophy. The question is, can they improve our clinical pathways? They offer a biologically plausible method for pre-endoscopy risk stratification, and they're particularly good for clinically relevant atrophy. The potential future application is to improve endoscopy quality by modifying the pretest probability, reducing unnecessary low-risk, low-yield procedures through targeted and enriched referral pathways, and moving from a symptom-driven to a risk-informed endoscopy. GastroPanel in particular is cheap, it's non-invasive, and it's a point-of-care test that can potentially act as a triage and a risk enrichment tool to optimize our clinical pathways. So this is how the present looks, and this is how the future looks. I will leave you with this, and I will ask you a question. If you know that a patient has a FIT positive test, do you do your colonoscopy slightly different to the patient with a negative FIT test? I would expect the answer to be yes. If you know that your capsule sponge has shown dysplasia, would you look more carefully in the esophagus? If you know that the GastroPanel shows gastric atrophy of significant relevance on the test, would you spend more time in your endoscopy and look at the stomach? Thank you.